Next part of Rasavahasrotas Hridroga, and based on feedback and some of the questions from our participants, Dr. Sharma and we thought about answering few of the questions of doctors, reasoning behind Ayurvedic prescriptions, or what is the logic or the rationale behind the Ayurvedic prescriptions. So I request Dr. Muralidhar Sharma sir to come over and just handle it. Thank you, sir. Welcome you, sir, and welcome everyone.
Last time we had some question like, what's the rationality of prescribing Ayurvedic medicines? I think I would deal with that issue as I consider in my practice, and later we go back to the Hridroga part as such. Luckily, I had an opportunity to present on the same issue of rationality of Ayurvedic practice just last week in Pune. I was presenting the oration about Vaidya Koladkar memorial oration, and the topic was the same, like how Ayurvedic practice should be established. So it's part of the same presentation, which I am repeating now here. First slide, please. Comes to the question of treatment, our Ayurvedic concept would have two components, Rogam and Aushadha. These are to be pariksha. Rogamadav pariksheta tadanantaram aushadham. What Charaka would say is, you need to examine the Roga first and Aushadha next. But there is one component of the Aushadha Pariksha. Roga Pariksha, we were discussing continuously on all the series issues about the Roga Pariksha part as such. Of course, there was some curiosity about the Aushadha and Aushadha Pariksha as such. With the Aushadha and the basic idea of Ayurvedic practice, as I perceive from the text is, a classical Ayurvedic practice would be, initially you would be examining the patient, and then the medicine would be prepared as per the requirement of the patient. This is what Charaka had started. So that's why in the Charaka, majority of the prescriptions would be following some group of drugs, suggestion of group of drugs, like Shat Chatarim Shat Kashayah or Shat Panchashat Kashayah, or the Dashayimani groups, like 10 drugs suggested as such, one group of drugs as such, than really a combination or a yoga. The number of yogas prescribed in Charaka Samhita are very few. There are a few of them which are disease specific. But in all, the basic idea would be, you will have plenty of options of drugs which would be selected according to the status of the patient based upon dosha, dusha, bala, kala, anala, prakriti, vayaha, etc. And then you have to prepare the combination. Then, of course, as the evolution of Ayurvedic practice, I would say evolution of Ayurveda, in the later Samhitas, as you go into the next Samhitas like Ashtanga, Sangraha, etc., you have more of yogas, whereas the number of ganas and their value, importance is seeming to be slightly reduced. It's more of the yogas than the other way. And yogas which would be having a disease-specific indication. When it comes to the next generation, that's Sahasra Yogas and Sharngadhara, it's full of yoga. Sahasra Yoga is one that where you have 1,000+ yogas mentioned. Then as the practice evolved like further, there was another edition, that Rasa Shastra, where you will have all that Rasaushadhis added to. With the Rasaushadhis, there is sort of a general perception, like Rasaushadhis are very target-oriented, disease-specific as such. That's where I disagree. My perception is totally different. My perception is Rasaushadhis are really a potented herbal aushadhis, cast aushadhis. It is basically the cast aushadhi content in the Rasaushadhi which would be producing the action as such, the disease-specific action or dosha-specific action, and hence the Rasaushadhis also need to be assessed based upon the dosha, dusha, kalpana. This is what I would feel, and that's how I have prepared, and my practice is based upon this basic idea that the Rasaushadhis also are based on the dosha, dusha, kalpana. I am not saying that it's a new concept, but general perception about the Rasaushadhis are supposed to be disease-specific, and you would like prescribe for a specific disease or a specific target area, which is, I don't agree, I have a disagreement. And because of that, my practice seems to be somewhat different from the others. Of course, for a beginner who starts practicing the Ayurveda, you will have still more confusing issues. You will have plenty of now new combinations, drugs like patent drugs, like where I don't know the numbers as such, and then you have the classical standard book preparations which are already suggested as the essential drugs by Ayush ministry, 277 drugs are prescribed, and then there are Anubhuta Yogas, and then there are many Ekamulika Prayogas, and of course, at the end you have Jagati Anushadam Dravyam Nakinchid Vidyate Vashatna and Artha Yogayoho. Everything is a medicine. So naturally, a beginner would always have a confusion like which are the medicines to be used and so on. I think I have referred to the issue in the beginning, like in my practice, I use around 33 plus 32 plus 40 drugs, which we have already suggested. Now, all that I would like to do is, I would like to present as I consider the rationality of my prescriptions. So, I limit to that of my prescriptions. First of that, the order is not totally alphabetical order. I have tried to maintain that, but it was not possible. But we will start with the alphabetical order. Agnituandi, one of the drug which I very frequently prescribe. Of course, the contents, I would say the major key contents. Now, whole of the contents, of course, all that is issue. We will not go into that part, preparation and so on. Key contents are the Vishamusti, Kshara, Lavana. These are the basic key contents which will help you to decide about the Dosha Dusha. Next slide. Now, each of these combinations which I am trying to suggest is, I assess the Dosha Dusha effect of that particular combination, either based upon what you see in the text and it's based upon the Kasta Aushadhis. At times, it could be based upon our clinical experience. As we try the drug over the patient, you will find certain perception of about the dosha. So, most of the times, my idea of the dosha affecting that drug by the drug would be based upon the textual combinations as such. Occasionally, it would be slightly different because you have multiple drugs at times, and it may not be possible to decide rationally based upon the text. You will have to decide upon what you see on the clinical experience. So, at times, there will be a bit of a overlapping of the clinical experience issue also. Now, Agnituandi Vati, based upon the contents of that Lavana, Kshara and Vishamusti, predominantly it's effective on Kapha Vata Vyadhi and particularly Kapha Vrta Vata. So, my indications for Agnituandi are, whenever there is a Shaitya Gaurava Shulani and Katvadi Upashayaha, whenever the patient has a feeling like either it's a Katurasa Dravya, something hot or such as the drugs, or Ushnakamatvam, patient prefers the warmth, Agnituandi is definitely indicated, that's a definite sign of Kapha Vrta Vata. A general perception like Agnituandi is limited to the gastrointestinal tract pathology or srotas of a specific dravya. I don't limit any of the dravyas to any srotas, though generally there is a preference for Annavaha srotas, but it's not necessary that Agnituandi should be prescribed only in Annavaha srotas conditions. Any acute colicky pain conditions where the patient would prefer to have some warmth over that, usually patients say like Shaka Kotra Kadimakta. This is what the people would say. Without bothering about the location or the status, definitely Agnituandi can produce some changes in the clinical outcome. Now, whether I prefer Agnituandi in all painful conditions or not, that depends upon the availability of other choices. Like a patient with a muscular pain, it may not be Agnituandi which is prescribed as the first choice. But if a patient presents with a muscular pain along with certain gastrointestinal tract pathology, I would prefer Agnituandi which would be suitable for both. So, that's the idea. That's how we can limit our prescriptions to a lesser number of drugs. Like example, a patient who has a gastrointestinal tract pathology like indigestion and he has a pain in the abdomen. At the same time, he has some muscular pain also, maybe due to injury or maybe swelling. I would not prescribe two medicines. Usually patients would say, my patients, I would always say, I don't give any specific medicine for your leg and abdomen. Of course, this is the basic issue which we have to, I always feel that we have to maintain this as our identity, because that's what we generally blame on the other side of the practice, like because the practice is too specialized, a patient would have multiple prescriptions. So what happens usually is patient would have some medicines prescribed as antispasmodic by somebody, and then the patient would go to an orthopedician would give an analgesic, and so on. And this is what we generally criticize. And I would prefer that our prescription should not follow the same lines. So in such a condition, it is the same prescription which can solve both the problems. So that idea of that dosha dusha helps us to minimize our prescriptions. So that's the basic idea. So my idea of prescribing Agnituandi is any of the conditions where you have these symptoms, irrespective of the other diagnosis. Now, the other diagnosis and all that issue which we discuss in the other sessions would be helping you to predict about the prognosis, possible complications, course of the disease, etc. But when it comes to the question of selection of the drug, I keep all that information in the background. All that information like in a gastritis pathology, endoscopic findings, or the other investigational reports and so on. And in case of renal calculus, and patient with the renal colicky pain, Agnituandi is my first preference of the drug. So the issue is, it's not about the suggestion about the Annavaha Srotas only. That's one of the important point. Now, same point, if a patient has a gastrointestinal tract pathology, and if the patient has that Kapha Vata Vata Lakshana, which is in terms of patient preferring to have either warm food or maybe warmth as such, you will find many of the patients who have that indigestion who say, after taking some shunti or soda or so, they feel some relief. Definitely Agnituandi is indicated. Whereas if you have another patient who feels that taking milk, the Shita is preferred as such, Sutta Shekara is my preference, because that's the sign of Kapha Vata Vata. So the basic idea is gastritis. Diagnosis is remaining gastritis. Endoscopic findings, of course, there will be some difference in the endoscopic findings, but they may be very much similar otherwise, unless certain findings which we can make out by because we are in Ayurvedic stream, we can make out certain differences there. But otherwise, it is in the same category. But your prescription would change, and that produces a significant difference. That's the basic idea of what I say, the rationality of Ayurvedic prescriptions. So that's about the group of disease conditions which I prescribe for as the choice of prescriptions for Agnituandi. Of course, the adverse effects, which I often have seen, not very frequent, but rarely seen with the Agnituandi is, particularly in a Pitta Prakriti patient, Agnituandi may often produce a hypersensitive rashes. So, in a Pitta Prakriti patient, I don't say it's not contraindicated. I usually, what I do is, I give medicines for 4 days, see the results, then I may continue. Even in many Pitta Prakriti patients, you can be administered for long duration without any harmful effects. But hypersensitive rashes, if they occur, you know that it's within 4 days it can occur. And the usual, my trend is, in a patient with the Pitta Prakriti and patient I had prescribed Agnituandi, I usually give it for a short duration, like 4 days, or at times could be 1 week, depending upon the other issues related to the patient. Then the long-term duration prescription would be given later, so that you will have that safety also. So that's how Agnituandi is prescribed. Similarly, now I will not go into the detail of all the drugs prescriptions to the same extent. A few of them we will discuss, and later we will just be quick about that. But I have cumulated all this information about the drugs as a presentable form. Right, next. Now, this is exactly how we have to select the drugs as such. And I remember Dr. Venkatesh Dwaisa, when he was an internee, he did that job. He started with that job of accumulating all the information about my prescriptions, and then I think still he has that book with him. And of course, whatever I am presenting is just an extension of what he did as the preliminary work. So I should remember that part also. It was quite a long time back. Now, the other drug is Ananda Bhairavi, where again, the key drugs, of course, it's the same thing. We will not go into the detailed part there. Next slide. Ananda Bhairavi, of course, the textual indications for the Ananda Bhairavi are Jwara, Kasa, etc., as well as Ajirna also is mentioned. But I prescribed Ananda Bhairavi in those conditions where there is, again, Kapha Vata Dushti, but predominant Ama Lakshanas, predominant Sama Lakshanas. Agnituandi is more of a Deepana, whereas Ananda Bhairavi is more of the Pachana. So when you have the Ama Lakshanas, and particularly Ama Lakshana with more of discharges as such, because you have a Grahi Dravya also along with the Pachana Dravya. And in that condition, Ananda Bhairavi is the usually prescribed drug. And the Sama Vata Lakshanas, as per the text, is very simple. Samam cha marutam vamam, where Staimitya Gaurava, when the patient has a feeling of a heaviness, lesser motility. In the gastrointestinal tract, the motility seems to be lesser, and the patient feels that snigdhatva, that many of the patients, if you keenly observe, the patients would say these complaints, like there is some either more of discharge in the mouth, or they may feel some oily or usually patients use the word pasavarpun, bad pasavarpun. This is the word they say like. And this is exactly what our Samhitas would say as snigdhatva, arochaka, and shaitya, shofa, when you have proctitis-like conditions, inflammations seen. Now when I say shofa, that shofa includes my endoscopic findings also. If my endoscopic findings show a significant inflammatory changes, I do consider that also as a shofa, though Sushruta or Chaka might not have used that endoscope and then identified the shofa, but we will include that as such. So in such conditions, so there again, Katuruksha Bhilashana, patient may prefer that warmth as such. Difference is when Agnituandi is prescribed, it's about those patients who do not have more of discharge and more of that this humid feeling, like that tendency of some salivation, etc. Ananda Bhairava is prescribed in those conditions where there is more of discharges. It could be diarrhea, dysentery, etc. Whereas Agnituandi is prescribed in those patients who do not have these symptoms. Then if there is a confusion, like if there is a overlapping of the symptoms, then I prescribe Agnituandi, Ananda Bhairava both. This is the advantage of Ayurvedic prescriptions. You can prescribe both the medicines together. And the idea of prescribing at the lower dose like 1 BD and giving 2 of the drugs, this would be helping you to make use of that kind of a target where the target-specific heating would be difficult. So you can broaden the idea of that. So it makes your clinical assessment also relatively easier. Certain of the areas, if you have some confusion, overlapping, you also have a choice of reviewing your approach maybe after a short duration, because it's not going to harm you anyway. Like in certain, occasionally, if there are certain few conditions, we may prescribe for 1 week. So by 1 week, when you see the results, when the patient gives you the feedback, you may have a review about that, whether you have to change over from Agnituandi to Ananda Bhairava or so on. But almost in 75% of the patients we can make out accurately if you look at the patients with this view. The whole problem is we have lost this kind of a view. We are either moved away from either contemporary system of the medicine, or many times we always prefer some shortcuts in the system. I am not saying that we should not use a shortcut. I do use a shortcut in my clinical practice, but that shortcut which we have developed is based upon the basic idea of looking at the dosha lakshanas of the patient. So ultimately when we prescribe the medicines, it's about the dosha lakshanas. So that's about what I prefer. And even in case of chronic appendicitis, now one of the areas where we have really, I always say with confidence, like the incidence of surgery in appendicitis, I have reduced it. In my patients, I think I have referred to that issue earlier also. The number of patients where the surgery required is now reduced significantly in my group of patients as such. And this is because of the facility of Ananda Bhairava. And I prescribe both Agnituandi and Ananda Bhairava together in case of appendicitis, because you have both the lakshanas, shofa as well as you have the admana. So I prescribe, that's the usual prescription. Agnituandi and Ananda Bhairava being prescribed together in case of appendicitis is a very common prescription which I give that. And you will get a significant satisfactory result also. So that's the basic idea of modifying the results, prescriptions based upon the clinical presentation as such. So that's about one issue. Even in case of malabsorption, of course, all varieties of the colitis, Ananda Bhairava can be prescribed. You don't have to bother about the bacteria or any other organism, microorganism, protozoa or bacteria. We don't have to bother. Ananda Bhairava definitely will produce the results. The only difference would be in terms of the duration of the treatment, maybe the possible complications, etc. That's a part which we discuss in case of the Roga Pariksha, the other sessions like. So basic idea of the prescription would be based upon the dosha lakshanas as such. Next of the drug. Now, Arogyavardhini is another drug which we usually, I prescribe, and one of the common prescriptions like. And in that condition again, the basic key contents are the rasa ushadhis like Tamravasma, Lohavasma, Abrakavasma, and then Katugrohini, of course. That's, I think, that's one part. So indications for the Arogyavardhini, I would consider all the Dhatvagni Mandya conditions. Dhatvagni Mandya conditions irrespective of the system involved. That's the important thing. So that's why my prescription of Arogyavardhini starts from a common cold conditions, Jara, starting from that, to very severe conditions like malignancy. So the range of Arogyavardhini, so in a real sense, it improves the Arogya. Arogyavardhini the meaning. So from that point of view, it's one of that very, and His clinic's name also is Arogyavardhini. No. So I remember about that all of a sudden. Flashlight. Okay, fine. The Arogyavardhini is that kind of a combination which would be suitable for a wide range of conditions. And my indications for Arogyavardhini starts from that common cold to the malignancy, and it involves many other conditions. Though generally the perception is Arogyavardhini is meant for hepatitis or liver disorders. It's not limited to the liver disorders. You can widen that. If you have an indication of any Pitta Varta Vata conditions or any of the Dhatu Agni Mandya conditions, whenever there is a Pitta Varta Lakshanas, there too Arogyavardhini is indicated. Again, when I say Pitta Varta, you may have again two categories, very common. I prescribe that two conditions. Pitta Varta Vata conditions with the Shula or Admana as a Lakshana, I would prefer Agnituandi. If there is more of discharge, then I would prefer Gandhak Rasayan. Gandhak Rasayan, which would have the Titta Rasa Pradhana Dravyas, and hence it would be Stambhana. If there is a problem like confusion, Arogyavardhini, Gandhak Rasayana together. So that's the advantage. That's the advantage of Ayurvedic prescriptions. If at all you have some confusions, if you are not very clear about, then you can prescribe as per the issues as such. So that's about one of the basic indications of the commonly prescribed drug. Right. Next. Next is Chandraprabha Vati, another very commonly prescribed. We go to the next slide. With the Chandraprabha, I would consider Chandraprabha as a Tridoshahara, and that numbers which I have given, Vata 3, Pitta 2, Kapha 1, is my own number, which is based upon my clinical experience. None of the texts would suggest about that. So if somebody differs, I fully have every freedom to differ with that. But this is based upon what I have perceived with my clinical experience as such. In terms of the Vata 3, Kapha 2, this is a very arbitrary number, so I don't give very high value to that. Of course, though it's a specific or more specifically used in case of Mutra or Sweda Mala involved conditions, when the Mala involved or Mutra or Sweda, it can be used in many other significant group of the drugs where there is a Dhatukshayajanya Vata Prakopa. So my prescriptions for Chandraprabha would start from a simple the senility, old senile patients who do not have any other specific disease conditions, and they want something like a treatment for the senility, vague prescriptions, to very specific indications like osteoarthritis. In osteoarthritis, my very common prescription is a Chandraprabha, because I consider that as a Dhatukshayajanya Vyadhi. Or similarly, the patients who have menstrual irregularities, of course, everybody prescribes that. But something different from the usual prescriptions which I do is, in case of osteoarthritis, any patients with neuritis-like conditions, particularly neuritis with certain deficiency symptoms, whether it's calcium or other way, again, certain of the issues, and I think certain issues we have referred to in the last session also, like patients who have these statin complications, etc. Diabetes mellitus, again, my prescription would be Chandraprabha first choice, along with the other medicines as such, and spermatogenesis abnormalities and so on. So the abnormalities related to those variant conditions where I consider that there is a Dhatukshayajanya Lakshanas, and at times it could be in combination with the other drugs, or Chandraprabha also could be prescribed in the course of a management of certain other disease. In between, during the course of the treatment, if I find that the Dhatukshayajanya Lakshanas have developed due to any reasons, irrespective of the other previous symptoms, I may prescribe Chandraprabha. Like a patient of these typhoid conditions, the febrile course is over, patient would have some deficiencies, then at that condition, instead of giving that Jwaragna Aushadhis like Lakshminarayan Rasa or Mrityunjaya Rasa, I would change over to Chandraprabha at that time. So that deficiency complications which can occur as a result of some other Vyadhi, some other disease, also can be managed with the Chandraprabha. So indications for Chandraprabha again would be wide varying. To make a complete list as a written list would be difficult, but I have tried to summarize to a great extent. So the indications would be changing as such. That's about the basic idea of the rationality of Ayurvedic practice, I think. Right, next. Another of the drug is Ekangavira. Again, we'll skip to the next, go to the next slide. And wherever there is a involvement of Mamsa Dhatu or Medu Dhatu with the Vata Kapha Vyadhi, and particularly Kapha Urta Vata Lakshanas, and among them, one specific Lakshana is where the patient would have a Pipilikanam Sanchara Iva Lakshana. Patients would use that exactly the same word, Pijin Battilaka Pundu. This is a very common symptom described by the patient. I don't know how the patient had communicated with Charaka as such, or Charaka has used the same word as such. And interesting, these are very interesting issues. Charaka has used the word 5,000 years back, and even now the patients use the same word. And I always highlight these issues as a speciality of Ayurveda, advantage of Ayurveda. Advantage of Ayurveda is the clinical signs are described in the same language which is communicated by the patient, whereas if you go to the contemporary textbooks, you will have very complicated words and you will have to open the dictionary and to see the meaning of that word and so on. Then the whole, you will have that Hanumanta tail program, like one after another. The issues will go on continue as such. But anyway, not a criticism as such, but whenever there is a need to highlight or focus on Ayurveda, I use these words also. Anyway, that's about one of the important indication as such. Wherever there is a Kapha, Vata, Vata, Vyadhi Lakshanas, and if the patient's pain symptoms are not stable anywhere, if it is moving, like patients say on some days it is pain in the legs, some days it is on hands or so on, moving sort of the pain, which also is a lakshana of the Chalaguna of the Vata, and a feature which you see in a Kapha, Vata, Vata Lakshanas. Or when there is a sparshanyata, abnormality of the sensations. It could be any of the sensations. I would prescribe Ekangavira. Again, it could be along with other drugs, like a patient with a neuritis. Chandraprabha and Ekangavira, they are prescribed together. The advantage is Chandraprabha would take care of the Dhatukshaya, Ekangavira will take care of the Kapha, Vata, Vata Lakshanas. So you will have an advantage of tackling both the ways. So that's how the medicines are prescribed as such. And the indications are as such anemia too, it could be neuropathy, it could be even advanced sorts of the neuropathy. Even in case of mechanical pathology like a spinal compression, spinal canal stenosis conditions too, Ekangavira can produce a significant change in the outcome. I am not saying that it's going to cure the condition, but you can produce a significant change in the condition. A patient who is bedridden for years together, if he is able to walk even with the support, even that's an advantage. I don't say that the patient would be normal, but a patient who is on catheter for years together, if you can, patient can maintain his bowel function without catheter, even that's a significant advantage. And these are the things which you can definitely contribute if you use these medicines. It may not be a final target like a patient being perfect. In many of the conditions, perfectly normal results may not be possible, but you can produce such significant changes which would be satisfying the patient and reaching to our goal of our treatment of Vedanayascha Nigraha. Of course, neurological deficits, when I say neurological deficit of all sorts, that I have tried to use that word as a very simple word, but it involves a wide range of neurological pathologies where it can be used as such. Of course, occasional adverse effect would be a burning sensation over the body or mouth ulcers also can occur, but not very huge complication. And administered along with the Avipattigra Churna, these adverse effects can be reduced. Probably it could be due to a dosha sthana or this vibandha complication. So once you give an anulomana dravya, these complications can be reduced. So most of the times, not always, most of the times, when I prescribe Ekangavira, Avipattigra is a common co-prescription which would avoid that possibility of seeing these adverse effects. So that's how I have planned this management. And these kind of the tricks, like combination of these drugs, it's based upon the experience. It's not that in the beginning of my practice I had this, but as we advance, as we see more, and that's exactly the advantage of using limited number of drugs in large number of patients. So when you use this limited number of drugs in large number of patients, you will have this kind of an extra, I think extra perception, a sixth sense of the perception, which will make your prescription somewhat fine-tuned as such. So that's about one more of the drug. Right, next. Another of the commonly prescribed drug is Gandhak Rasayan. Next slide, please. In the Gandhak Rasayan, again, it's I consider this as a Tridosha Hara Dravya. Of course, the ratio, at times in those conditions, when I see the fix that ratio, it's purely my own perception. So don't search for any textual support about that. And of course, the major indication is it's one of the Rasayana Dravyas, and particularly in all Shonitaja Vyadhi, Rakta Dushti Lakshanas, it's indicated. So my prescriptions in all that, it's a basically Kushtagna. So whenever there is a Kushtha Lakshanas, of course, it's a Vyadhi Pratinika. But in the Vyadhi Pratanika also, when there is a Kaphaja Kushta Lakshanas, where a patient would present with more of itching and discharge, definitely Gandhak Rasayana would produce the results irrespective of the causes, whether it's a pyoderma or whether it's a teniasis, whether it's a fungus or bacteria. I would use Gandhak Rasayana. But there are people who say that Gandhak Rasayana is used as an antibiotic, as a sulfa. I don't agree with that kind of a perception. I always criticize that kind of a perception. If you have to give sulfa, you use the sulfa. Gandhak Rasayana is not a sulfa. Of course, it contains sulfur, and a sulfur drug doesn't contain sulfur essentially. So that's the other issue. So that's because of ignorance of the biochemistry. Otherwise, we use that kind of a comparison. So I don't say that way. And I don't prescribe Gandhak Rasayana as an antibacterial drug. But I do prescribe Gandhak Rasayana in my postoperative patient, and I can avoid the antibiotics. That's the issue. Now, this again, that needs some clarification, because at times, many of my students also felt that Gandhak Rasayana is an antibiotic because it is prescribed in the postoperative period for the wound healing, and the wound heals. So it's not as an antibiotic. From my point of view, I never say Ayurveda would have anything antibio, against life. It's against the principle of Ayurveda. Ayurveda is for life. So I will never use that antibiotic as an Ayurvedic idea. I don't say that antibiotic should not be used, but when you use the antibiotic has to be used as it is. Anyway, that's the other part. But Gandhak Rasayana, I would use this as a Rasayana Aushadhis, where it can help in prevention of the possible complication of the Pitta Srava conditions due to any condition, including the inflammation of the wound. It can prevent that, and almost in every acute or chronic wounds, it's used as such. Infective lesions of the skin, irrespective of whether it's a pyogenic or the other way. These are of course very common prescriptions, but Gandhak Rasayana I would use as a first choice of the drug in patients with anorectal disorders like hemorrhoids, fissures, etc. In that condition too, Gandhak Rasayana is used because it's again a Pitta Rakta Dushti Hara Vyadhi. It can avoid the Rakta Dushti as such. So, and of course, worm infestation and so on. So, the indications of Gandhak Rasayana also would be quite wide varying, and another very frequently prescribed drug by me. And of course, occasionally seen adverse effects or skin rashes do occur occasionally, and of course, it's not going to produce any persistent complication. It can be withdrawn. That's all the basic issue, right? Next part. Another of the drug is Tribhuna Kirtirasa. We'll just skip that to the next. It's a predominantly Kaphagna Dravya, particularly Kaphaja Jvara Lakshanas and Kapha Prakopa Lakshanas, even minimal Kapha Prakopa Lakshanas. I would use Tribhuna Kirti, and of course the Lakshanas of the Kapha Prakopa are Gauravam, Shita Mutkleshaha, Romaharshaha, Anidrata. So all that conditions which we would have in the initial stages of the fever, and particularly in the Kaphaja Kala and Kaphaja Jvaras, Tribhuna Kirti is more preferred than Mrityunjaya. So many times my prescription changes in the month of November, December, from Mrityunjaya Arogyavardhini to Tribhuna Kirti Arogyavardhini, particularly in children. Now, of course, November still it's not cold yet, but when it becomes somewhat cold and the patients would have these respiratory symptoms, usually my prescription changes. Otherwise, my usual first choice of the prescription would be Mrityunjaya Arogyavardhini. But in these seasons in children, my prescription may change to Tribhuna Kirti and Arogyavardhini based upon the clinical presentation of the Kaphadikya Lakshanas. And of course, it can be used in even case of the febrile involuntary conditions, gastroenteritis conditions as such. Occasionally, it may produce a gastrointestinal irritation like nausea and vomiting. If the child has already nausea and vomiting, I would not prefer Tribhuna Kirti, then I would prefer Mrityunjaya Rasa. That's the basic idea. Of course, not again a very serious issue. When I say about the adverse effects, it's not about a very critical issues, but occasionally you may come across that kind of effect. Right? Next is the Mrityunjaya Rasa, another very commonly prescribed drug. If you screen my prescriptions, probably Mrityunjaya Rasa comes number 1, Chandraprabha comes number 2, Kishor Guggulu comes number 3 among my prescriptions, and this is one of the top prescriptions as such from that point of view. Next, the indications, of course, again I would consider this as a Tridoshahara, and again the ratio is arbitrary, Vata 2, Pitta 1, Kapha 2 as such. And the indications are whenever there is a involvement of Rasa Pradoshaja Vyadhi, irrespective of the doshas, if there is a Rasa Pradoshaja Vyadhi, I would prescribe the Mrityunjaya Rasa, and every other condition of ama, every indications for ama, I would consider Mrityunjaya Rasa as one of the choice of ama pachana drugs. And when I say ama, it's not only about the anarasa, it's not about only the gastrointestinal tract abnormalities. Ama is described by Vagbhata as Kodravebhya Vishaseva Udanti Amasa Simbo. So even abnormal biochemical reactions, any biochemical reactions producing abnormal results, so RA factor, I consider is ama. Uric acid, I consider is ama. ANA raised, I consider this as ama. So my scope of perceiving the ama is quite wide varying, and I always say that ama can be objectively identified with the laboratory investigations, maybe bit over exaggeration. If somebody says it's over exaggeration, okay, I'll accept that. But it can be a practical suggestion also, like ama can be identified biochemically in the clinical practice, and hence a range of indications for the Mrityunjaya Rasa would be wide varying, like starting from common cold to almost every autoimmune disorder. Every autoimmune disorder, one of the common prescription which I prescribe would be Mrityunjaya Rasa, because it is one of, I consider this as a choice of Amapachana Dravya. It's not that, it's the only drug, you may have better drugs also, but my selection in my kit of practice is these drugs as such. And the indications are any of those conditions where there is a Sama Vyadhi Lakshanas and Samavata Lakshanas like Nidra, Nasha, Brahma, Shwasa, etc. I think that's something of the textual description. Next. So now I think we will go a bit faster, otherwise we may not cover all the issues. So Shwasa Kuthara Rasa. Next. I would consider this as a Kapha Vata Haradravya, and whenever there is a Kapha Vrta Vata Lakshanas as such, where you particularly Kapha Vrta Pranavata conditions, specific about Kapha Vrta Pranavata conditions, where you have Tandra, Sadaha, Aruchihi, Stevanam, Kshavatu, Udgaraha. It's not only about the breathlessness, it's not only about the asthma as such, bronchitis as conditions. It could be in any of those conditions where the patient would have the Stevanam, Kshavatu, Udgaraha. The abnormalities like more of spitting or maybe this sneezing or so, and irritations, so on. Shwasa Kuthara can be prescribed as such, and of course, as the word says, it's more specific about the Shwasa Vyadhi. So it's whether it's a Vyadhi Pratanika, Dosha Pratanika. I would consider this as Dosha Pratanika. Vyadhi Pratanika, of course, is true, but it's not only the Vyadhi Pratanika which decides about the indication of the drug. It can be Dosha Pratanika also. So we'll have to assess the Dosha Lakshanas. Indications could be even in case of carpulmonale, you can produce certain results. But usually in carpulmonale, I would prefer Shwasa Kuthara with Punarnavamdura, which is a Shotagna. So combination of these would be helping you to have more of that target specific action as such. Of course, occasional complications which can occur would be skin pigmentation, particularly if Shwasa Kuthara is not prepared properly because of the Manashila as a content. You will have that skin pigmentation as a complication, which is often troublesome. So when I prescribe Shwasa Kuthara or dispense Shwasa Kuthara, I would be limiting my the resources of Shwasa Kuthara to very few reliable companies. Many of the marketed Shwasa Kuthara products may still have that Manashila which is not processed properly, and the indication that complications of the skin pigmentation can be quite troublesome. I am not very serious, but once the pigmentation occurs, it can remain for a very long duration. So if you use Shwasa Kuthara of any other, and again, as I have told you, I will not announce the name of the company which I use in public, because that becomes certain other issues. But if you use Shwasa Kuthara of such conditions, there is a possibility of these complications, and these can be biologically identified. The complications can be biologically identified. So bit careful about the source of the Shwasa Kuthara. That's all the point which I would say. And interestingly, even if there is a complication of that deposition can be managed, cured with the Arogyavardhini. Arogyavardhini can help you. Suppose you have a scope, I would prefer most of the times, wherever there is a scope, usually my Shwasa Kuthara prescription would also have a combination of Arogyavardhini followed by, which would be suitable for both the issues. It may be helpful in the management of the disease, because most of the indications of the Shwasa would also have the Dhatagni Mandya Lakshanas, so Arogyavardhini helps that way also. And any possibility of that cumulative toxicity of the Manashila can also be prevented by Arogyavardhini. This is certain of the simple tricks of the practice, but it can help a significant results as such. Next part, Sutta Shekhara Rasa. Next. And of course, the indications, as I have already referred to, in Pitta Vrta Vata Lakshanas and Amla Pitta Lakshanas, and where there is a Pitta Kapha Pridhana Vyadhi, Sutta Shekhara is definitely an indication. And it can be, it's not only the gastritis. Even a patient who has the sinusitis, where you have the Pitta Kapha Lakshanas, Sutta Shekhara is my prescription. The difference is, when it is a gastritis, it could be usually prescribed with Agnituandi Sutta Shekhara. When it's sinusitis, it is prescribed with Mutriyan and Sutta Shekhara. So by combining this, you will be able to target the dosha. So ultimately, it's about the doshas as we perceive in the patient, doshas which we perceive in the patient, which would be the guideline for prescribing the drug as such. Occasionally, there could be an adverse effect of constipation. And again, constipation can be easily managed with the Avipatikara. So most of the times, my usual prescription when I prescribe Sutta Shekhara, Avipatikara is another co-prescription, so that you will not have that problem at all. Not that every patient requires that, but this is to make your treatment more acceptable, to reduce the possibility of patients' complaints later. So to have a better feedback, this is the usual prescription which I prescribe. Like next, Kanchanara Guggulu, another of the drug. Next part, any of those Kapha Pradhana Vyadhi and particularly Medo Mamsashrita Kapha Vyadhi. Medo Mamsashrita Kapha Vyadhi, where you will have a Vruttonatam Chashvayatham, where there is a nodular swelling as such, which is comparatively painless. Again, I will not say tumor, cancer, any of that. But specific indication which is mentioned is in our text is a Vruttonatam Chashvayatham, which is produced due to Kapha Lakshanas, where usually it is painless or maybe very mild painful conditions, non-inflammatory swellings to a certain extent to be translated. I would prescribe the Kanchanara Guggulu. So irrespective of whether it's malignant or benign, any tumors, Kanchanara is indicated. Along with that, of course, Galaganda, which is a very specific Vyadhi, the specific condition mentioned in the text as such, it's also used in the osteoarthritis, very chronic osteoarthritis conditions, very chronic and third degree, where you have the joints which are not able to support, and usually a surgical indication as such. In that condition too, if you, though it's not going to cure, but the changes which can be produced would be significant when you prescribe Kanchanara Guggulu. Again, I am not saying that the joint will be recovered completely structurally, but there will be a significant functional improvement when it is prescribed as such. Obesity, of course, is a usual prescription in the Kanchanara Guggulu as such. Right, next. Kishor Guggulu is another very common prescription. Of course, the contents, I would prescribe this whenever there is a Vata Pitta involvement, and particularly Raktavrata Vata. Any of the Raktavrata Vata conditions. Again, the Lakshanas of Raktavrata Vata also are a very broad idea, and irrespective of the contemporary diagnosis. Contemporary diagnosis, it could be quite different, a wide ranging as such, but whenever there is a Sadaha, Arti and Anganyasaha or Mamsantaraja Shvotaha, then a extra synovial edema seen in any of the joints, my indication is Kishor Guggulu. So it is prescribed even in case of gouty arthritis or in case of the rheumatoid arthritis. In case of the rheumatoid arthritis, when there is a local inflammatory sign, local temperature is raised and tender swelling, it is Kishor Guggulu and Mutriyan which is prescribed. When the swelling has become less tender and the local signs of inflammation are lesser, but it's a intrasynovial effusion, there is a accumulation of the fluid in the joint, my prescription will be Gokshuradi and Mutriyan. So this way, according to the status of the disease, it's when I say rheumatoid arthritis, I don't mean to say every rheumatoid arthritis patient is prescribed Kishor Guggulu and Mutriyan. It's about, based upon the dosha lakshanas which we see, to have this kind of a presentation would be quite difficult as such, because the whole spectrum as such, but I think that gives you the idea as such. Varicose veins, varicosities, another area where Kishor Guggulu, all rather vascular pathologies, where there is a vascular stasis. It is again Vata which is involving of all the vessels. I don't make the difference between arterial disorders or the venous disorders. Contemporary science, you will have two categories, arterial and venous. But for me, Vata is one. And both arterial and venous disorders, Kishor Guggulu is prescribed. whenever the patient with peripheral ischemia, where the amputation is advised. If at all I have saved a few limbs, it's because of the Kishor Guggulu, and of course Manjishthadic Sharabasti is the other way. That's based upon the same perception. The perception like there is a involvement of the Vata Rakta as such. So that's about the issues. Almost all peripheral ischemic disorders, Kishor Guggulu is a common prescription. Of course, you may combine Kishor Guggulu with the Gandhak Rasayan if there is a wound and discharge. When there is more of this emaciation of the limbs, it could be Kishor Guggulu and Arogyavardhini, or if it's about the local inflammatory signs, Kishor Guggulu and Mutriyan. The combination could be based upon the other clinical presentation, but when there is a involvement of vascular involvement, Vata Rakta Lakshanas, Kishor Guggulu is a common prescription as such. Next, of course, the Triphala Guggulu. Next, in the Triphala Guggulu, particularly it's about the Tridosha. Again, my numbers, Pitta 2, Kapha 2 and Vata 1, arbitrary. And any of the conditions where there is a involvement of Mamsa as such or Medas as such, it's any Mamsaja Vyadi or Medoja Vyadi. I have referred about the Mamsaja Lakshanas. Mamsena Katina Shopaha Vibaranaha, when there is a sign of inflammation. That's the basic difference between the Kanchanara Guggulu indication and the Triphala Guggulu indication. Kanchanara Guggulu indication, when there is not much of a sign of inflammation. A swelling presenting with the sign of inflammation, my prescription would be Triphala Guggulu. It's basically Guggulu preparations. That's how we change that prescription based upon that. And of course, Harsha Pipilika Nam Sancharaha, when there is a Shofa with the Pipilika Sanchara Lakshanas. Pipilika Sanchara Lakshana mentioned about in Vata Vyadhi, Ekanga Virarasa or Triphala Guggulu, that's based upon the other presentation. When you have that Pipilika Sanchara Eva Lakshana without the swelling, localized swelling, Shota, it's the Ekanga Vira. When it is presented with a localized swelling, it's a Triphala Guggulu. So that's how the indication vary, and it's exactly based upon what the text would suggest as such. And of course, to make it as a general indications, of course, almost all vranas, wounds, I think that's missed there, I should have added that. Then tonsillitis, pharyngitis, ulcer, any of the ulcers of course, and fistulae, all sorts of the conditions, Triphala Guggulu can be prescribed. So next, Kankayanivati, next as such. The indications for Kankayanivati, I would say this is a Pitta Kaphahara Vyadi, and any of those conditions where there is a Rakta Pitta Dushti, and Rakta Pitta Dushti would be when there is a discharge of blood, whether it is from the nose or from the rectum or throughout the body, anywhere. And among the clinical conditions which is more frequently, it's about the bleeding hemorrhoids. Bleeding hemorrhoids where there is a Pittaja hemorrhoid Lakshana, Pittaja Arshas Lakshanas, my prescription would be Kankayanivati, along with the Gandhak Rasayan. Gandhak Rasayan and Kankayanivati would be prescribed in that condition, hemorrhoid condition. I think that's what we have discussed in the earlier session about the management of hemorrhoids. I have suggested about that possible choice of the treatment based upon the clinical conditions as we assess. And I think we have referred to all that issues about the dyssynergia and related clinical presentation issues. So based upon that, it could be prescribed. Even menstrual irregularities, when there is a irregular bleeding, not profuse. If it is a very profuse bleeding, then you may have more specific drug like Chandraprabha. But if it is a moderate bleeding, a regular spots, like regular spots, Kankayani is a better choice of the drug. Or even in case of hypertension, cardiac myopathy, Kankayani can be used because of its the involvement of Rakta Pitta Dushti as such, its management of the Rakta Pitta Dushti as such. Of course, one of the common adverse effects is loose stools, again not very serious. We can just caution the patient, like when you take these medicines, you may have a few loose stools for 1 or 2 days, but that's all. It's not going to harm, but it's better to keep the patient sensitized about that possibility. Next, now Makaradhwaja is another of the drug. Next, and when I say Makaradhwaja, I always prescribe Suvarna Ghatita Makaradhwaja, not the Suvarna Yukta Makaradhwaja. Again, I have all reservations about that Suvarna Yukta Makaradhwaja. Again, we will not go into that issue again, make the controversy more. But whenever there is a Dhatukshayajanya Vyadhi, and particularly Shukradhushti Lakshanas, in that condition, I would prescribe the Makaradhwaja as such. And in all, particularly whenever there is a Rasayana, emaciatory features, Makaradhwaja is one of the indications, and Kapha Bhataja Vyadhi. Very chronic respiratory conditions like bronchiectasis, chronic non-healing ulcers, and abnormalities related to spermatogenesis, these are the common indications for the Makaradhwaja, which I prescribe, limited to a few of the patients. Like next, Next one. Then the aristas. Now these are certain of the rasaushadis which I use regularly. Then a few of the aristas, abhayarista, of course very commonly used, and I would consider this as the tridoshaja hara, and particularly when there is involvement of the rasarakta as such, when you have the vibandha, ajirna or agnimandya lakshanas are all grahani lakshanas. And the sama kapha lakshanas, in these conditions, sama kapha or sama pitta lakshanas, in these conditions, and particularly when the lakshanas are ajirne anne jirnam pakkum tinayava or akasmatva muhurbaddam akasmat shitilam, when the patient has irregular bowel movements, particularly occasionally diarrhea and occasional constipation, altering constipation and diarrhea, in that without any specific disease diagnosis. Now usually if you go to the textual, the general clinical science, alternating bowel habits are related to the sprue and so on, but it's not necessarily, I would not say as necessarily sprue, but you will have plenty of persons who would have this kind of presentation, not as a constipation, not as a regular constipation. And I think that part also we have discussed in the previous sessions as such. My prescription would be abhayarista than avipattikara. Avipattikara for those patients who have a regular constipation as such, when there is a altered bowel habits like occasional diarrhea and occasional constipation, which I don't always make a diagnosis of grahani, muhurbaddam, muhurdrauma as a lakshana of grahani. Of course, it's a lakshana of grahani, but not necessarily named as grahani as such. In that condition, it could be a choice of the drug. So hemorrhoids with that kind of dysenergia and related issues, habitual constipation conditions, malabsorption pathologies, of course, and occasionally abhayarista may produce a griping pain. So again, not very critical, but when the patient has a phase of constipation, and during the constipation phase, if you give abhayarista, the initial bowel movements may produce some griping pain, not constant, so there is no need of caution as such, but it's better to sensitize about this issue to the patient so that patient would accept that easily. So next, Amritarishta is another very common prescription of mine, and the indications are all kapha vata lakshanas, of course in all jvara vyadhis, and every rasa pradoshaja and sama vata conditions. So very often almost the indications are that of the Mutriyan rasa. So Mutriyan rasa and Amritarishta can have very common prescriptions as such, and as in case of Mutriyan rasa, the indications are almost the same. So most of the times my prescriptions would be Mutriyan rasa and Amritarishta are co-prescribed, or occasionally one is replaced by the other, rarely. So that's about the choice as such. Right. So irrespective of the diagnosis, all febrile conditions, I would prescribe Amritarishta as such. Right. Next part. Ashwagandha is another of the drug as such. Wherever you have features of kapha vata lakshanas and mamsa medoja lakshanas, and in particularly langana ayasa ruksha ushna kamatacha, when the patient has a feeling, complaints, particularly in the limbs, of a pain produced after exercise, langana ayasa, or due to reduction of the food intake if the patient feels loss of energy, less energetic when the patient doesn't take the food, or when the patient does the exercise, that exercise intolerance in terms of the pain. Now, exercise intolerance in terms of the breathlessness is a different issue, but exercise intolerance in terms of the pain or muscular spasms as such, and ushna kamatacha, when the patient prefers that warmth, usually, as we have discussed, like particularly in case of the mamsajagata vyadhis, if the patient says that like there is a spasm and keeping a warm water bag relieves the pain, ashwagandha is better indicated. So that's how I prescribe it, and of course it's a very common feature in all cases of the neuritis. Most of the patients of neuritis would have this condition, particularly middle-aged patients, so-called calcium deficiency. So calcium prescribed by the contemporary prescriptions, when I replace that calcium, I prescribe ashwagandha. Not that ashwagandha is a supplement for calcium, so it's not that way, but that's why I use that so-called calcium, like it's a sort of deficiency, and that deficiency is made up. And I will always say ashwagandha is a better deficiency supplement than the calcium, which is very specific. It's not about only the calcium, it improves the total metabolic capacity of the tissues, and hence it helps in the relief of the symptoms as such. And of course, all the degenerative disorders also, ashwagandha is indicated. Sorry, next. Ushira Asava is another of the drug as such, commonly prescribed. And whenever there is a lakshana of Rakta Pitta again is Urdhvam Nasakshi Karnayoho, when there is a discharge of the blood, particularly from the Urdhva Bhaga, Nasakshi Karna, the ears, eyes and so on. In that condition, Ushiras or even Kupitam Romakupebhya, another of the specific indication, collagen tissue disorders, where there is a capillary fragility and the patient would have rashes seen, erythematous lesions seen over the body. Ushirasava is another of the specific indication which can be given. So it's not only about the menstrual disorder or urinary tract disorders. But of course, menstrual disorders is always my first choice of the drug. I do not prescribe Ashwagandha at all. I always prescribe Ushirasava in my prescription, which is generally different from the general trend. The general trend in the practice is Ashwagandha with the bottle itself would have a female face, but I never use that Ashwagandha at all. That's the usual thing. But anyway, we will not go into much of those controversial issues. But my experience is something different there, and in all that conditions where there is a abnormality of the menstrual irregularities, particularly Rakta Pradarakshanas, when there is more of discharge, it's about the Ushirasava which is prescribed, and urinary tract infections and bleeding disorders. Occasional adverse reactions could be constipation. Again, not very critical, but it could be one of the common complications. Right. Next, Kumari Asava is another very frequent drug. Next part, wherever there is again any of the conditions where there is a Dhatvagni Mandya, Arogyavardhini and Kumari Asava, almost any case of Dhatvagni Mandya, it's a common prescription. Now, when I prefer Arogyavardhini or when I prefer Kumari Asava, it would be depending upon the other possible issues in a patient. At times, it could be Arogyavardhini and Kumari Asava together. It also depends upon the other issues. These variables would be very somewhat subtle. It's very difficult to objectively define that, but it depends upon what you see in the patient. Either when you see that there is a predominant Dhatvagni Mandya, we may combine both Arogyavardhini and Kumari Asava. When it is moderate, like a child who is presenting only with that irregular appetite and so on, particularly children who are addicted to this lace, kurkure and so on, and they have that irregular appetite and mother says that child doesn't eat, it's only Kumari Asava. It's not Arogyavardhini which is required. Alone, Kumari Asava alone would help in that way. So that kind of differences would be somewhat subtle. It's very difficult to define that. But any of those vague gastrointestinal tract symptoms which will have present with that features of Dhatvagni Mandya, Arogyavardhini, this Kumari Asava is prescribed. And of course, all malabsorption. Dysmenorrhea is another of the condition where Kumari Asava is often prescribed. Of course, that's what the textual description would say. Textual indications also are the same message. Right. Next. Khadirarishta is another of the condition, a drug as such which I prescribe, whereas there is a Raktavrata Vata and particularly involving the Rasarakta Dhatus. So in that condition, particularly where you will have the Shwayatuhu and Mandala, when circumscribed lesions. Again, I would not say ringworm or teniasis, so on. So it's not about that, but one of those features which you remind about that, what Mandala would be suggested. It could be any other erythematous rashes. Khadira is indicated. Septic foci, particularly in children, this happens pyoderma-like conditions where non-specific. A child would have multiple spots of infective lesions and none of the diagnosis is possible. It could be often streptococcal infection which is seen as such, and antibiotics have helped, have not really solved the problem. In that condition, Khadirarishta is one of the sure shot remedy. So this is one of the common group of the children who are brought to Ayurvedic clinics, like having that non-specific, again it doesn't specify any specific disease condition like a pyoderma, having that repeated reddish rashes, pus formation and so on. Very common these days. These days it has become quite common. Earlier it was believed to be unhygienic condition, but what I would say is it's because of the over caution or a wrong perception of the hygiene. Often the hygiene now is perceived as application of some these smelling agents, powders or scents and so on. So often this produces a break in the skin and that produces the damage. And my advice to such patient is not to use any of that. It's only the soap and water to be used, nothing else for taking bath and none of the other chemicals. And Khadirarishta, it helps, and it's one of that our strong areas, one of the areas where our Ayurvedic treatment can produce a very huge change in the outcome and patient's perception also. And of course, rarely in case of a severe anemia, patients who have a very severe anemia and doesn't respond to the usual standard protocol of the treatment for anemia, like Draksharishta, Brahmana Aushadhis are not helping in, and where there is a tendency for the bone marrow depression, my preference would be Khadira there. Khadira, because it's mentioned as one of the Kushtagna Dravyas, and Gambhira Dhatugata Kushta would always have the Pandu, and whenever it is accompanied with the manifestation in the skin, of course, Khadira would be a better preferable drug. Very often seen in case of very chronic psoriasis conditions. Anemia is often seen, and in that condition, Khadira would be a better choice of the drug. Like next, Mustakarishta is another of the drug which I very commonly prescribe, and particularly in Kapha Vataja Vyadhi and Agnimandya, when the patient has Agnimandya Grahani as such. So Kapha Vataja Vyadhi, either Ananda Bhairavi or Mustakarishta, or at times it could be Ananda Bhairavi and Mustakarishta together. This is what I usually prescribe. Majority of the times it would be Ananda Bhairavi and Mustakarishta together. That would be convenient to the patient. Not necessary that it has to be prescribed together, but almost the indications are the same as that of the Ananda Bhairavi. Another choice for Ananda Bhairavi as such. So next as such, next. Saraswatarishta is another of the drug, of course the key contents as such. The indications for Saraswatarishta are all the, again I would consider as a dosha, the ratio is arbitrary. When I have mentioned any of the ratios, these ratios are arbitrary based upon what I have perceived, and whenever there is a Ojakshaya and when there is a need for Medhya Rasayana, the indications are there, and Ojokshaya Lakshanas are exactly the features which you see in case of the anxiety neurosis. Bibeti, Durbalaha, Abhikshanam Dhyayati. So when the patient feels that he has a fear as such, or then he feels weak as such, Dushayaha, Durmanaha, these are very frequent issues. Now most of the times, most of the people would have this kind of anxiety and anxiety neurosis issues, and Saraswatarishta is one of the specific prescription which I prescribe, and even if it's not only a function, it's not only a functional, even if there is an organic pathology, even then Saraswatarishta could be indicated. It's not that Saraswatarishta is limited only to the functional disorders, organic disorders also it can be prescribed as such. Right, next. Khadirarishta is another of the common prescribed drug, and the indications could be, again I would prescribe as one of the Pachana Dravya, particularly Pittavrta Vata Vyadhi Lakshanas and Pittavrta Vyadhi Lakshanas, where you will have Katuka Amla Ushna Vidahehi, when the patient would have a precipitating factor like Katuka Ushna Amla Aharas. Those who have this Gobi Manchuri the previous day and next day having that pain in the abdomen, it's Khadirarishta which is a prescription, very specific. So Gobi Manchuria and chicken also. The Khadirarishta is a very, okay, or maybe with the Gobi Manchuria, 1 cup there. Okay, all right. The other part. So that's how I prescribe, and that gives you a very gratifying result. The issues are those which will give you a very gratifying result as such. That's exactly the point. A patient having that abnormality, gastrointestinal tract abnormality due to ice cream and coming to me next day, I would prefer Kumari Asava. If it is the other way, Gobi Manchuri, it's the Khadirarishta. But the problem would be when a person has taken both ice cream as well as Gobi Manchuri. That's a problem. But I don't mix up. But usually in such conditions, my preference will be Jiraka. That's it. Right? So all colics, when I say this, all colics as a symptomatic treatment, most of the vague conditions where the patient would have a vague pain in the abdomen and causes are not very specific, not very organic disease conditions, you are not able to make out the diagnosis, but intestinal colic, I think I have referred that issue, intestinal non-specific intestinal colic now is identified as a ICD diagnosis, ICD-10, it is diagnosed as a 6.42 as one of the specific diagnoses, so there is no hesitation to say non-specific intestinal colic now, and in such conditions it could be administered as such. Khadirarishta is another of the drug. Right, next. Draksharishta, of course, another very common indication, and as a Brahmana Dravya. Brahmana Dravya where the patient has the mainly Vataja Vyadhi or Pittaja Vyadhi Lakshanas. Draksharishta is prescribed, it could be anemia, all anemia shedding disorders, chronic bronchitis or neuritis conditions. Again, Draksharishta is prescribed as a common drug like. Next. Pippalyasava is another of the drug as such. And Pippalyasava, very commonly, I think it's a very popularly known drug which is used in case of bronchitis. But my prescriptions are limited, not limited to the bronchitis. It could be in all patients presenting with Agnimandya, and particularly Agnimandya with that jadya, the heaviness in the abdomen, which is a typical of Agnimandya Lakshanas. Mandagni Lakshanas are presented. And the patient has a tendency for the vomiting, not clear-cut vomiting, but feels like vomiting but doesn't have the vomiting. In that kind of a symptom, chardi, it's not exactly the chardi, but when the patient would have a chardi features, in that condition, Pippalyasava is very specific. Now, you will come across such patients quite frequently. Patient feels like vomiting but doesn't get the vomiting. If there is a frank vomiting, it may not produce the same gratifying results. But if that kind of a presentation occurs, and which is common, one dose of Pippalyasava produces certain magic results. At times it's what I say as magic results as such. So one dose is enough. Patient feels that comfort immediately. That's one of the indication. And of course, any of those patients where the patient would present with another very vague symptom but very specific is Roma Harsha. Roma Sartapun. Patient would say, causes, of course, modern diagnosis, it's not possible to make out the exact causes, but you will come across such patients as such. Pippalyasava is another, irrespective of the diagnosis. Now, irrespective of the diagnosis, if you prescribe that, the patient would find the result as such. That's another of the interesting issue. And Bahalam Madhuram Chayas, patient would have a feeling of sweet taste in the mouth. By Didi Tipatipapum. Patient would say this kind of the symptoms also. And in that condition too, Pippalyasava is another specific drug, very specific. Now, it's not about disease specific, it's not about the Vyadhi Pratanika. This, and I don't say it's a symptomatic treatment also, but you will come across a good number of patients where these symptoms are presented, and it's only our Dosha Dusha combination can explain those symptoms. Contemporary diagnosis may not make out that difference in these clinical symptoms. We may have a very vague diagnosis like a gastrointestinal tract abnormality, gastritis and so on. But with these clinical symptoms, when you have a specific identification of the dosha lakshanas, it can be prescribed as such. Right, next. Now, I think, though I have not included all my prescriptions, there are a few more left over. I thought it would be enough. Otherwise it would be boring, and its majority of my prescriptions would be with this. There are a few more prescriptions which are not really included, not with any purpose, but I thought it could be limited as such. And all I would say is, it's not necessary that it has to be the same drugs which are to be used. You may select any of the Ayurvedic prescriptions for you, but once you analyze your prescriptions, the medicines in your kit on these lines, dosha dusha lakshanas, definitely you can prescribe very efficiently and the results can be seen. And that's exactly what our Samhita would say, like when you have all these vargas, the groups which are mentioned, and whenever you have a choice based upon the availability. In those days, the choice would be based upon the availability. Labha, alabha were the choices. Now it may not be labha, alabha, maybe labha in the different language also, commissions, percentage, value, and so on. So anyway, that all other conditions or other aspects of your selection of the drug would be valid as such. But once you have limited a few of the drugs, if you have a perception of about your prescriptions with this kind of view, and consider that dosha dusha lakshanas, that's yete vargaha dosha dushadhi apeksha. Once you have that dosha dusha assessment, you may administer in any form. Bhagbata has limited that kalkakwata sneha leha, it could be kalkakwata sneha leha, or it could be rasaushadhi. One more added, new addition to what Bhagbata has said. It gives you the results as such. It could be administered in any form like paneyanasya, anvasane, antar bahirva, lepabhyamgehi, grantirogan. So ultimately it comes to that point where we identify the dosha dusha combination of indications of that particular dravya based upon its rasa, guna, virya, vipaka, or maybe the combination as such. Now, last part in that issue is, the basic question is about whether the roga pariksha is important or the aushadha pariksha is important. Charaka has given you a perfect solution about that. The choice is always rogamadav pariksheta tadantaram aushadham. But the situation now which we are facing is, we have the aushadhis ready with us, and you have to select a patient who is suitable for the Aushadhis. Chance or facilities of preparing the Aushadhis after seeing the patient are rarely available, are almost difficult. I would not say impractical, almost difficult. So we need to get adjusted to the present day situation where you have the Aushadhis with you and the patient has to be chosen who will fit to the Aushadhis. And that gives you a sort of confusion with the Ayurvedic perception, but there is no need of confusion as such. And Paschat Jnanapurvam Samachareta, when you have this kind of a perception about your potentials of your weapons, the Aushadhis, then you can use it in any of the patients based upon the jnana as such. Naturally, the question comes in like whether the Roga Pariksha is important or Aushadha Pariksha is important. The answer given by Charaka is very important. Yastu Rogam Avidnyaya Karmani Arabhate Sada Karmani Arabhate Bishaka Api Aushadha Vidhanajnaha Tasya Siddhiri Adrichaya. If you have a perfect knowledge of the Aushadhi, occasionally, accidentally, you may get some results. But when you have a perfect background of the Roga, that perfect knowledge of the Roga also, so you have a perfect assessment of the status of the Vyadhi, and at the same time you have a perfect assessment of the Aushadhis also, and when they are matched together, Yastu Roga Visheshajnaha Sarva Vaishajya Kovidaha Desha Kala Pramanajnaha, those who know about the Desha Kala Pramana, the dosage of the drug, of course, Desha, availability of the drug, Kala is the current season, like you should be able to have a contemporary mode of prescription. The contemporary mode of prescription I would suggest, what I prefer is 2 tablets, 1 kashaya, 1 tablet, 1 powder and so on. So there is some general perception about the Ayurvedic prescription in the patients which we have to somewhat meet with. Not necessarily, these are not the essential aspects of the practice, but somehow you can reach to the expectations of the patient. With that, Tadaha Siddhihi Asamshayam. This is what Charaka has said, and what I have pursued in my practice also is the same. I think I have answered that question of indications for the rationality behind Ayurvedic practice somewhat satisfactorily. Right, so next. So that's about the one basic issue. I think I would not go beyond that. If there are any more questions, we can discuss about that issue later. Now the other part which we are left with in the previous was about the Hridroga. Hridroga again, the areas of Hridroga is a quite wide varying issue. So to cover all the areas would be difficult. So I have tried to concentrate this with the limited scope of what we can do in Ayurvedic practice or what I can do in my practice. Again, I would limit to that based upon my clinical practice as such, because there is one area where we have certain serious limitations, severe limitations in the area of the cardiac pathology, and most of the times, in majority of the conditions, it's the responsibility of identification of the disease than really the management. So, right time of identification, right opportunity of identification of the disease would become more critical than really whether you can manage or not. So, certain of such issues would be the point of discussion. Right, among them, again, I would try to cover up this area, though it's a very broad areas, I would cover up under these heads like congenital heart disease, ischemic diseases, cardiac failure, cardiac myopathy, inflammatory disorders as such. Right, next part. Now, next slide. The congenital heart diseases, again, I will not go into the detail as such, it's not the cardiology class, but causes of the congenital heart diseases are many, but primarily there are 2, genetic factors and environmental factors. Both of them are preventable. So wherever there is a possibility and there is a scope, prevention of a congenital abnormality is better than the other way. So and these are certain issues, many times the patients come to us like premarital genetic assessment, whether it is necessary or not. Suppose a patient asks me that question, I would say definitely yes, is necessary. The known established factors like consanguinity before marriage, wherever there is a possibility, we can suggest that these are not to be done within our limited scope. So though we may not take up the responsibility of preventing that. As well as the environmental factors like the pathology like rubella, another common question like patient having this rubella pathology, this Gora, and whether they have to take this and these immunological suppressant drugs or not, or that immune suppressant drugs which are given as such, or antiviral drugs as such. whether they can produce the fetal abnormalities. Of course, they do. And we do not have, I don't have any definite method of preventing that. As far as I know, I don't have any definite method as such. So in such conditions, whatever the available facilities, they need to be adopted. So my Ayurvedic perception shouldn't come in the way of preventing these possible complications. That's my policy. So I would not come in that way as such, but these facts are there. Next part, next slide. Now, about the incidence, the prevalence of congenital heart diseases are quite common. So whenever a pediatric case is examined, we have a responsibility of identification of these pathologies as such. The overall chronic heart diseases, congenital heart diseases is quite frequent in Asia. That the longest line, this is about the regional, that second line is in the Asia, where you have a significant number of congenital heart diseases. A simple auscultation can help you to identify many of those congenital heart diseases. So I take up that as a responsibility. Identification of the congenital heart disease, it may not be possible to manage many of them. I don't say that we have a very effective management for all congenital heart diseases, but if we can identify, and I take that credit, many of the unidentified congenital heart diseases identified when a patient has been brought to me for some other conditions, and then recommending the patient go for a evaluation and then whatever there is effective management. But that can help the patient as such. And in majority of the congenital heart diseases, virtually there is no medical treatment. It's only either a surgical treatment or at times it could be a palliative treatment choice as such. But next, the majority of the conditions, surgical indications. And in South India, now this is about the statistics from different sources. South India, people are more aware of the surgical treatment, and that black color is the surgical treatment. The third column is about the South India. Compared to North India, Northern India, the surgical treatment for the identified congenital heart diseases are lesser. Many of the child would be carried over to the adulthood with the existing congenital heart disease. Now, I will not go into the other issues like how far this would be effective or not, but when you do not have a very other definite treatment, I would always suggest that the child has to have a surgical consultation, and possibly wherever there is an option, surgical treatment has to be preferred. And there are mild, not so significant, insignificant congenital heart diseases. Once it is proved that it's a insignificant congenital heart disease based upon the echocardiography findings, then virtually there is no need of any other specific treatment. Only the issue is try to prevent the respiratory infective pathology. So advice about the diet, exercise, and most of the times palliative treatment can be without any specific medications. Right, next part. Next asset. So what the general physicians can do, I think that's what I have summarized. Like we have a very, let me accept, like from my point of view, I say that there is a gross limitation from Ayurvedic treatment point of view in treating a congenital heart disease, but we can definitely contribute by identifying it an early disease as such. Whereas a congenital heart disease identified in adulthood, that's another issue where definitely we can produce some changes. Next slide. Now, congenital heart disease in adulthood, if a patient has survived the congenital heart disease for 50 years, then I would assure the patient like you don't have to undergo surgery, which is something contradicting to what the other cardiologists would say. And this can produce, it's a very simple logic. If a person has survived for 50 years with that pathology, he can survive for another 25 years with that pathology. And so there is no need to be bothered about that. So, and this is what I have done to my patients. And I have seen many patients who were diagnosed with congenital heart disease at the later age, gone for surgical conditions and developed more serious or at times fatal complications even. And outcome of surgery in the adulthood for congenital heart disease is throughout a poor, this is again collected from the graph, it's not Ayurvedic view, it's from the collected from the universal, major source of WHO, a publication reference are there, which gives you the outcome, and outcome is poorer and more poor when the number of surgeries are more. First surgery itself, the outcome, that downtrend of the graph shows that cumulative survival period, which is always in the lower trend. More the number of surgeries, second, third surgeries and so on, that reduces the success rate as such, irrespective of the specificity. And most of the critical conditions, critical congenital heart disease conditions, do not allow the person to live up to the adulthood. So if a person has lived up to the adulthood with a congenital heart disease, there is some scope where we can manage. Right, next part. And of course, the management there would be, it's only to prevent the possibility of either a stroke. Now, in all congenital heart disease, one possibility is about a possibility of the stroke developing due to embolism, or a cardiac myopathy, or overloading of the heart due to the heart pumping failure. Both these can be managed in the other category which we discuss later. Now, the other group of diseases, other coronary disorders, cardiovascular disorders, or cardiac disorders other than the congenital disorders, they are primarily of either ischemic heart disease, which constitute the major group of the cardiac pathologies. Hypertensive heart disease is one group. Rheumatic heart disease is a relatively minor group as such, and inflammatory diseases are comparatively lesser. A cardiac pathology resulting in a cerebrovascular complication is another group of the condition, that stroke developing due to a cardiac pathology, an embolism produced. Now, in this condition again, anticoagulants are the platelet aggregation inhibitor drugs of any category. It could be the ecosprin or the clopidogrel and so on, which are usually used. And most of the patients would have been prescribed that. I would not stop those prescriptions. If the patient comes to me with these prescriptions, I would not stop those prescriptions, because as far as I know, we do not have any such definite method of prevention of this. So if a patient has already a tendency for the cardiac pathology, and if the patient is on such treatment, I would not avoid that treatment. I would say that you continue the treatment, and whatever the other need as such, depending upon the patient's condition, I would be managing that patient with my prescriptions as such. So that's the only one way of preventing that. There is no other way of preventing that as such throughout. Of course, the diet, exercise is another issue, which is a universal phenomenon to prevent any cardiovascular pathology. So in such patients who have a tendency for this, the stroke due to any cardiac pathology, pre-existing cardiac pathology, congenital or otherwise, a possible risk of cerebrovascular complications, the only means of preventing is either platelet aggregation inhibitors or occasionally anticoagulants, rarely. So that's the choice. Again, I will not go into that complex issue of selecting those drugs as such. If necessary, we may do that. The next part. Now, the question comes in like from Hridroga as such described from our Ayurvedic text point of view. The Vataja Hridroga mentioned is obviously the ischemic disorders, where the patient would have the shula, Vatena shulyate atyartam yudyate sputati vacha, that acute pain in the substernal area, which is a typical feature of the ischemic disorders, is exactly the Vataja Hridroga as such, and it can be even producing moha, shwasarodha, alpanitra, shwasarodha, even it can result in a respiratory failure as such. So the whole series of the possible complications of ischemic disorders are described as Vataja Hridroga as such, very obviously. So next. Now, when the patient presents with the ischemic disorders, particularly myocardial infarction, from the contemporary, we need to be knowing about the contemporary issue also. The issue is quite fluid. The diagnosis and the definition of myocardial infarction itself is a very rapidly changing issue. Before 1950, myocardial infarction was most of the times a post-mortem diagnosis. Only after the patient has died, if you do the post-mortem, the evidence of the ischemia was made out. A clinical diagnosis of ischemic heart, this myocardial infarction specifically, was almost negligible. The first definition started in 1959. WHO had given the first definition, and that first definition of myocardial infarction was a substernal pain accompanied with the ECG changes. It was limited to that. Then the definition were revised at periodical intervals. I will not go into the all. The latest definition is 2019 fourth guideline of myocardial infarction. That the next, that first, the current existing myocardial infarction diagnosis, 2019, released in January. So the current definition of myocardial infarction would be based upon these 5 categorizations. Type 1 myocardial infarction is an accidental pathology where there would be a sudden rupture of either the vessels or maybe erythematous plaque and produces a sudden obstruction where there will be not much of a pre-existing symptoms and a massive, usually there will be a massive pathology, and often the results would be very critical, serious as such. Virtually, I consider that as a condition where we will have a very minimum scope for management at present, because we are not in such a efficient means of preventing that, because the condition would be very fluid, patient may have very serious critical conditions. So the only issue is identification of that condition clinically. It could be the pain, and one of the important clinical feature would be pain accompanied with the sweating. If a patient has a substernal pain and has sweating, I would not waste time. I would go for the specific investigations to make the diagnosis as such. And you may have a bit of error on the other side. You may have a bit over-suspected. Some of the conditions may have over-suspected, but that over-suspicion is better than missing a critical condition. So one of the general criteria is pain in substernally and patient would have a sweating. I would consider this as a potential case of cardiac ischemia, and then the effective handling has to be done. Type 3 is again a myocardial infarction where there would be again sudden development of the pathology, where there would be again unexpected conditions where the exact reasons are not known, often produced due to embolism or thrombosis. Again, very mysterious conditions which are very difficult to identify. So our basic responsibility would be to identify that type 1 and type 3. And type 1 and type 3, I would always prefer to refer the patient to a cardiologist or some other facility where you have a monitoring facility, because these conditions require a continuous monitoring. So I don't have much of an experience of treating that conditions. But type 2, one hit, just you hit one, I would consider this as a opportunity to treat. Type 2 is those conditions where the patient would have the symptoms of cardiac ischemia, even troponin levels, maybe enzyme level may be raised, but it's often due to a prolonged complication like hypertension or some other chronic conditions, a chronic ischemic condition. That's exactly where we have an opportunity to treat. Type 4 and 5, they are limited to the operative conditions. Type 4 is a patient with a stent or the catheter in and developing the ischemia. Type 5 is a ischemia developing during the surgery, which are not really within the scope of our practice. This is a cardiologist condition. So type 4, 5 is somewhat not of consequence from our clinical practice point of view. It's limited to the issues related to the cardiac surgery and cardiologist domain. And then the definition of myocardial injury is another area which is a new addition to the definition of myocardial infarction, where non-ischemic injuries are identified. And this is another area which we come across in the usual clinical practice. One more, next part. That these injury conditions or non-ischemic myocardial injury conditions, causes could be many, which we come across quite frequently when we handle many of the chronic conditions, patients with hypertension, stroke, renal disorders, hyperthyroid conditions. Ischemic pathologies or features of the ischemic pathologies are often seen in the cardiac conditions. Clinical symptoms may mimic that. No need of panic about that. Wherever there is a possibility, we need to treat those primary conditions like severe anemia, patients having the pain. There is no need of panic. If you can manage that anemia efficiently, the cardiac complications, even the troponin level, can be managed as such. So cardiac injuries produced as a secondary complication is another set of the conditions which are not really cardiological conditions, but the basic issue is a clinical identification of those conditions exactly, and then in that condition we can manage without specific cardiac management. Of course, wherever there is a possibility, we can manage these primary conditions. Suppose it's a condition which we cannot manage, like a severe advanced renal failure, where the patient's creatinine level is 9, 10 and so on. So again, there is a limitation. So the issue of whether we can manage those patients or not again becomes a very elaborate issue. So I will not go into that elaborate discussion, but we have to know our limitations. Within our limitations, there is some scope for the management. Now, next, the identification, again, basic issues. I think I will not take the ECG classes, but the again, to go into all the details of the ECG findings in ischemic pathology is not the issue. But whenever you have a ST segment variation, if you have ECG, now these days ECGs are quite common and ECGs are provided in the clinics and you get the opinion over the line also, so you have the other facilities. But if you have a ECG with an ST segment variation, if you are not very confident, if you are confident, okay, we can handle, but I would suggest to have a second opinion. Have a second opinion. Many of these ST segment changes may be innocuous, may not be very critical, but some of them may be critical. So when you are not able to make out clinically, it's better to have a second opinion so that you can filter out those critical conditions. That's the point. So you will not miss those critical conditions as such. So next part. The basic issue is, another is, you have to identify these two notches, the P wave notch and T wave, Q wave notch, if the gap is wider. So I have tried to summarize very briefly, simplest possible explanation of a possible ischemic findings. If you see any ECG recording where these lines are having a higher gap, try to either, if you are not confident, if you are thorough with the ECG and then if you are able to make out the diagnosis, fine. I am not saying that these are always a sign of a definite infarction, but if you find these and if you are not very confident, it's better to have a second opinion, confirm whether it is a really serious critical condition or not, because these are the often ECG signs seen in the critical phase as such. These are the often initial signs of the critical phase as such. So that's one word of caution. Of course, there is always a reservation. If you are, I am not saying that I will be following only these. We can have a better perception if you go into a more detail about the ECG findings. But ECG findings also have a limitation. It's having only an accuracy of 70 to 80%. More than 20%, there is a possibility of missing the diagnosis even with the ECG. So next, now the current, the latest, or maybe the current contemporary, a confirmation of the diagnosis by the troponin level. Of course, earlier CKMB was the criteria. Troponin are the, now even that in the troponin, now you have a high sensitivity troponin, TPN investigations, bit costly. But troponin levels are almost reliable and a standard benchmarks for the diagnosis of myocardial injury or ischemia, both infarction as well as injury. But in a typical infarction, you will have a gradual trend, like the first, after about 24 hours after the infarction, there is a tendency for the raise and it continues to be there high for about 48 hours to 72 hours. Then there is a tendency for the gradual reduction. And there again you have a limitation that first 24 hours, even that troponin level might not be a very dependable. So series of troponin investigation would be required whenever you have a suspicion of a myocardial ischemia. Now next, that troponin indication would be another guideline to suggest about the prognosis. Troponin level, higher the troponin level, higher the mortality level. So another basic idea is, if you have a patient with very high troponin level, better to transfer the patient to some other, so that why should you take the blame? If the troponin level is lower, there is some scope for the management. So when I select the patients for management, I would consider these issues. The troponin level also is one of the criteria by which I would prefer whether I have to continue the treatment or refer the patient as such. Higher the troponin level, it's better to send the patient to a facility where you have more dependable, more objective assessment as such, and then management also, which also would reduce the burden on you also. Next part. So the general issue is, summarize all that issue is, if a patient has a normal ECG, of course, you can be 80% safe. 20%, of course, there is always an open issue. You can manage, you can observe the patient, wait and watch, and if there is any changes in the clinical symptoms, of course, we may take a decision. If there is a ST segment changes, but no changes in the troponin or CKMB, this cardiac enzyme level, still there is a scope for wait and watch, but you should be more cautious about that. A repeated examination may be required. But if the troponin levels are higher and there is a ST segment elevation, then a definite myocardial infarction, and I would always consider that as beyond the scope of what we can manage. So that's how I select the patients with the ischemic cardiac pathology. Now, those conditions which, next slide. Of course, it's the same summary of whatever I have discussed, so we can skip these 2 slides. Next slide also. It's the same summary, the standard protocols diagnosed, and those standard protocols, next slide. So, in such conditions, where I consider that it could be managed, my prescriptions would be Prabhakara Vati, Chandraprabha and Arjunarishta would be my prescription with all these limitations. Like, my prescription would be only when I consider that this patient can be managed with our patients. Of course, our management as such. And there would be a if the patient is already having a co-prescription for hypertension, definitely yes, that hypertension needs to be managed. Or if the patient has a fluctuating blood pressure, again you may have to have the management as such. If that's again what I have told earlier, platelet aggregation inhibitors, if they are already prescribed, no question of changing that. That may have to be one of the lifeline in such patients to prevent the complications. Lifestyle modification is something which we can definitely produce some change in terms of the diet and exercise, and that constitutes a very significant component of the management of the chronic ischemic heart disease conditions. Next. So that's about the issues or incidence of the myocardial infarctions as such. Type 2 conditions are quite frequent. Now, that blue line is the type 2 myocardial infarction. So when I say this, don't feel that you have a lesser opportunity to treat that. Now, when I have said that there is a serious limitation to treat the cardiac pathology, that doesn't mean that the number of patients whom we treat would be lesser. The number of patients in that type 2 myocardial infarctions are quite significant as the age progresses. Younger age, it's mainly the type 1 which is more frequent. As the age passes by, later the older age patients, majority of those are the type 2 conditions. So, again, this also is one of the components which I would consider when I take the patient. Younger the patient, definitely we would try to, because there is a possibility of having this type 1. Older the patient, you have a safety, and comparatively that's manageable. So that's about the issue of opting for the patient with the myocardial infarction as such. And with this, we can have a significant results as such. Next part. Now, the caution is they are the largest causes of the death in India, and particularly the most common would be of the cardiovascular death among the causes of death in India as seen in the 2000 Register General records. So, point is you have to be careful about this issue, and naturally you have to safeguard yourselves when you have a high risk of the fatal outcome as such. Next. And another very important issue, incidence of this myocardial pathology is increasing, and it's increasing in the younger age. The less than 30 years of age, the incidence is increasing every year. This data is from India. Now, this is not from management point of view, but from the clinical identification point of view. Usually we had a general norm earlier, like below 30 we would never consider cardiac pathology. But the incidence is increasing, and it's coming to a very high percentage value of 27 in the last 2019, 2007 to 19, 2009 to 19, last decade. The incidence has increased remarkably in younger age, and that's why you need to have a more caution as such. And this is again from authentic sources of the data. Right, next part. And another is the incidence of myocardial pathologies are increasing in the developed nations, whereas they are reducing in developing nations. So naturally, the textbooks which would give you some guideline, which are usually the modern textbooks from the Western origin, they would give you a green effect, green picture, like you have a better outcome. But virtually, that's an area where you have a more serious issues in our conditions. Developing countries as a whole, it's not only in India, but in India, of course, the issue is more. The next part. And in India, another important issue is in all these coronary interventions. Now, again, I will not go into the controversy. In the modern cardiology, you have that new two categories, interventional cardiologists and non-interventional cardiologists, and there is always a fight with them. And I think lots of articles are published about these issues. I will not go into that part, that issue. But the management with interventions, like angiography and so on, that has become very common now. And in good number of conditions, there is an unnecessary intervention. Now the people have come to a level like where at the age of 40, as if you are having an overall engine of your car, you will have a angiography and flush out those vessels. That kind of a perception has come in the society. That's a bit of over-exaggeration. There is, I boldly say that that kind of over-exaggeration is not necessary. The basic issue is you need to take care of the diet and lifestyle, and if you can take care of the diet and lifestyle issues, you can make a significant change as such. So that's the other part. And of course, the budgetary provisions for the cardiovascular stent market, and now of course with the Ayushman Bharat these guidelines, costs of these stents have reduced remarkably, and stents have become more popular now, and people with the stents and these prostheses, they are now very frequent as such, and that produces another practical clinical problem when we handle such patients, like the pre-existing medications in those patients, whether they should be stopped or not. You may manage with any other drug, but if the patient is an anticoagulant or a platelet aggregation inhibitor, my word of caution is not to touch that. That prescription has to be maintained, and in such patients, it's always better to share the responsibility on somebody else, because once the patient has a stent, it's something like walking on the wire. There is always some perception threat, and hence keep that option of cardiological consultations and management open. Keep it, let the patient go to the cardiologist also, and whatever you have a scope for the management, definitely we can prescribe. So certain extra reservations about that dealing with the patient is necessary. Right. Next, another very important study and a very useful issue. Among the causes which are studied by a huge group, this is a study published in 2019, a huge study where a large number of patients throughout the globe are studied, and the most important cause, the first line for the cardiac pathology is dietary risks. And our government and the whole policies as a health policy has now selected many options of dealing with the cardiovascular pathology with the least concern about suggestion about the dietary issues. There is a basic need to recommend to the people, or at least to ourselves, the value of the diet and lifestyle as a part of preventive. Goli bhaje or batatambade after the seminar definitely would be more harmful than a simple idli or dosa. Very simple issues. So minor issues, very minor issues. It could be the overall consumption of the food intake, overall reduction of this exercise also. Very common, one of the important cause for the disease, the cardiovascular pathology is the vehicles, automobiles. The moment you come out of the doorstep, maybe certain of the people may have some vehicles going into the house also. So the moment you walk out, you will get into a vehicle, and then everywhere you move in the vehicle, that itself, automobile industry, the development of that automobile industry and incidence of cardiovascular complications. These graphs are almost similar. So these are very minor issues, and they produce a very significant change. Now, there is a need to show that to the society by ourselves. Now, simple. I have kept it at a policy, like once I go to the campus, college campus, till I come out of the campus, I don't move in the car. Within the campus, I have to move. I don't use the car. Now, it's not that it's going to produce a huge change, but whenever I have to move from the hospital to college, number of time, I prefer walking. I never use a lift to go further rounds. Many of my students would be panting when they go to the second floor, and they will be blaming like why this fellow doesn't move, because in front of me they can't use the lift as such. I have never used the lift in my hospital except when I have to accompany some guests as such. So very simple issues. But these simple issues which we consider and which we can recommend to the patient, or which we can practice and demonstrate, I think that can produce a significant change, and there is a very huge need for this kind of a perception and this kind of educating of the people to the as such, to reduce that possible burden of the cardiac complication. That's all the point like. And of course, the other issues like high systolic pressure. Last slide about that. This next slide. The whole, now there is again a huge report. Now these are all from reports from various sources, but interesting issues. This is from this Germany. They have made a summary of what you can do as such. It's borrowed, it's not my perception, but I agree with this. Like, how to prevent the cardiac complications as such. They have given a summary based upon the statistics again. If you reduce the total cholesterol, you can reduce the risk by 50%. If you can reduce the blood pressure by 6 millimeters of mercury, you can reduce the risk by another 50%, and 42% of the stroke complication can be reduced. If you avoid the cigarette smoking, you can reduce it 50%. But don't ask me, like, if you have not started the cigarette smoking, what you do. So if you have reduced the body weight, then you can reduce it by another 35-50%. Physical activity of minimum of 15 minutes of exercise, rigorous exercise, it can reduce by 55%. Food and vegetables, having plenty of fruits in the food as such, it can be reduced by 20%. If you consider all, the risk can reduce by 90 to 95% as such. That's the point of education, like, where there is a huge source or huge scope for intervention where there is no need of medicines. It's not the question of medical management. The other part of the management which comes a important issue, and this is exactly based upon Ayurvedic line. I am not saying going against Ayurveda or other than Ayurveda as such, but it's absolutely the practical issue which we need to demonstrate. And before educating, it has to be practiced. Right, next the part. Now, the other, that's about the ischemic heart disease. I think I would not go beyond that. Now, the other cardiac pathologies, myopathies and pump failure conditions, which very beautifully described in Ashwagandha, like Hridayam, Stabdam, Barikam, Sashma Garbhavat. The like a stone is persisting in the abdomen. This is a very particular, very perfect description. And many of the patients with the congestive cardiac failure, they would exactly use the word this is the exact word used by the patient, and it is again used by Bhagbhata as such. And Kasa Agnisadhanischivaha, breathlessness produced, are the exact clinical symptoms. So about the clinical identification of the congestive cardiac failure, the description mentioned in the text is perfect. Now, next part. Now, the basic issue is cardiac myopathies. In all the, irrespective of the cause, once there is a burden on the heart becomes dilated. Having a bigger heart is a sign of disease. Vishala Hridayakal. It is a sign of the disease, whereas there are virtually no disease except constrictive pericarditis, where the size of the heart diminishes and produces the disease as such. So, hypertrophy of the heart is a very common issue, and it can be identified clinically. By simple palpation and auscultation, you can identify the cardiac hypertrophy. But the whole issue is all hypertrophies need not be considered as the sign of the disease. Particularly if there is a eccentric cardiac. Now, eccentric hypertrophy is where you have a more of volume, but the wall is not thickened, which is often a physiological. Like persons who do regular exercises also may have a bigger heart, but that may not be a sign of the disease. Whereas when you have a concentric hypertrophy where the wall becomes thickened and the volume of the ventricle becomes diminished, which can be seen with the echocardiography. You need to have echocardiography investigation, and that will suggest concentric hypertrophy conditions, you have more risks as such. Outcome would be poorer. Whereas eccentric hypertrophy conditions, the symptoms are better, or outcome would be better. So this also is one of the factors when I go for selection of the patient, like when I have to prefer a patient for management or not. If there is an option, a concentric hypertrophy, I would try to avoid that, because usually the outcome would be poorer. But eccentric hypertrophy patients, which also are good number in patients with cardiac hypertrophy, they can be better managed, outcome is safer comparatively. Right, next. Now, the basic idea of these cardiac failures or cardiac hypertrophy, the current classification, they are classified into 4 classes, and the class 1 is where there will be no symptoms and virtually no limitation of the physical activity. It's only on a rigorous exercise. The limitations of the exercise are reduced Person can walk one floor easily, but second floor the person may have a breathlessness, and it could be a sign of a first stage of the cardiac hypertrophy. And identification of that cardiac possibility at that level is very important. By that you can postpone the later complications effectively. That's the important idea. And in all, whereas in advanced conditions like a class 4th, where the patient would have a severe limitations of the exercises, and you will have all that classical clinical features of the congestive cardiac failure like pedal edema, it's not a very huge issue because its identification is very obvious. But the important is early conditions where the patient would have a mild symptoms, and early identification is a very critical issue, and there that careful auscultation is a important issue. So irrespective of the patient's clinical conditions, have a practice of auscultating the cardiovascular system, and you can identify such risks at least in a good number of patients, though not in all, and can have some preventive steps as such. Without any symptoms too, we can identify. That's all the point there. Next slide. Now, once you have identified the patient as a congestive cardiac failure, the outcome, the survival period, again, second graph is about in India. The others, of course, the global, this is about the global statistics compared to other countries. We will focus on India. The possibility of a death due to cardiac complications, 1 year mortality within a year, once you have reached that stage 4th in congestive cardiac failure, irrespective of the treatment, now irrespective of the treatment, possibility of a death in 1 year due to cardiac complications is quite high. That reddish component, pink component is the blue component is non-cardiac death as such, and the yellow component is again unknown causes of death. This is based upon the statistics. So leave those two parts. The important is the possibility of death due to cardiac complications within a year after making the diagnosis of congestive cardiac failure is significant in our conditions, irrespective of the treatment. I am not saying like whether Ayurvedic treatment or modern treatment. I refer to this issue because when you deal with the patients, this is important, prediction of the risk as such. And if a patient has died within a year or so, it's a supportive issue. You need to say like, it's exactly the point outcome. I don't say that the patient can be cured. But if your statistics comes to at least to that level and can have the same issue, then you can say that you have a effective treatment. So that's all the point. My purpose of referring to these statistics is from that point of view only. Sorry, next part. My preference for the treatment in such conditions, with all these reservations, selection of the patient and then the possible risk factors as such, my preference for the patient would be Punarna, Mandura, Chandraprabha and Prabhakara Vati, considering this as a Kaphaja Shotha or Kaphaja Hridroga. When there is a pronounced edema, it's a Kaphaja Shotha, where you will have more of Punarnama-like drugs like Mutrala Aushadhis. If it is a Kaphaja Hridroga, it's the Prabhakara Vati, which is more specific for the cardiac pathology as such, and of course Kapha Vyati drug as such. I think in the list of our drugs I have not included that Prabhakara Vati. So that's the part like. Then comparatively the incidence of carditis, pericarditis are comparatively less common. Very rarely you can come across. But you may see a few of the patients of pericarditis. These days pericarditis conditions are increasing, particularly in diabetic patients. Diabetic patients, I don't know, but the statistics somehow is showing a very significant rise as such. So occasionally we may come across such patients, and my prescription would be Kishor Guggulu, Mutriyan, Arishta, along with whatever the patient is having the other prescription as a co-prescription. Now that's what I say, as a co-prescription along with the other medicines. Rarely you come across the patients with these kinds of the symptoms where you will have a carditis, pericarditis conditions. Tubercular, often the treatment would be tubercular, anti-tubercular treatment which is required, particularly diabetic. Now, patients with chronic diabetes and having a breathlessness as a symptom, you need to have a echocardiography, and a good number of patients show these incidents. And again, I don't know the exact reason, and nobody knows the exact reason, but as I have seen in the last 10 years, number of such patients is increasing as I have seen. The reasons I don't know. So another area, grey area as such, and of course this is the opinion of many other cardiologists also, many other medicine persons also say that incidence is increasing rapidly. So exact reasons are not known, but one of the word of caution, a chronic diabetic patient having a breathlessness symptom, and a persisting cough as such, a cardiac evaluation is necessary. Many times, clinical identification often is not possible. A moderate effusion may be missed clinically by your auscultation as such. So, a echocardiography done in such patients would be often necessary. Next part. Now, rheumatic diseases is another area where, of course, I would consider this as a Krimija Hridroga. Krimija Hridroga mentioned by Bhagbata is exactly the same of rheumatic diseases, and it's considered as a Shigrakari Vyadhi according to Bhagbata as such. Management, of course, next part. The incidence of rheumatic diseases also are quite significant in our area. In India, the incidence is quite significant, so we'll go to the next part. And the prevalence in India, it seems to be reducing as per our ICMR statistics. The incidence is reducing compared to 72 to 75, 2001 and 7. The incidence is reduced. Again, reasons of course are many. We don't know, we will not go into the issue. So, incidence of the rheumatic diseases of course has reduced significantly compared to a few years back what we have seen. But any patient with a throat inflammation, pharyngitis or tonsillitis, one of the risk factor is a possibility of the rheumatism. So, take care of the pulse rate in such conditions. Very simple, basic clinical issues. Take care of the pulse rate. If the patient shows a significant tachycardia, a word of caution. That patient has to be re-evaluated, and there is a possibility that it could be the early sign of rheumatic carditis. Next, prevention, of course. I would now, the usual line of treatment which is suggested, recommended throughout is a prophylactic penicillin, patients with a prophylactic penicillin. And I have a good number of patients where this prophylactic penicillin could be stopped with our treatment of Amavata. Gokshuradi Mrityunjaya Amritarishta is my usual prescription, Amavata prescription, the same logic which we have discussed earlier. And it can be effectively prevented, but again a sensitive issue, avoiding this penicillin prophylaxis, and people may have a lot of issues there. So, a word of caution about that part also, a lot of confusion may be there. But if possible, or if the patient is ready, definitely yes, we can produce a equal amount of the results, results as such of prevention. But acute rheumatic carditis, you may need the penicillin prophylaxis. Without penicillin prophylaxis, it may not be possible to manage. I think that component, that part, we have referred to in our first issue when we have discussed about the Jwara and the Jwara Vyadhi Lakshanas. There we have discussed that part as such. So, next part. Last part is arrhythmias, another of the grey area. Patients having the arrhythmia, missing a heartbeat, could be due to anything, like according to our literature, you may miss a heartbeat due to many reasons. But the other way, the disease conditions which could be produced due to a non-cardiac issues, they are to be identified first. And a simple electrolyte imbalances, thyroid disorders, alcoholism, drugs, stress, sleep apnea, genetic causes can be a cause for the missing heartbeat, where there may not be any specific treatment for the arrhythmia. And the person can live with the arrhythmia as such, or if there is a need, the need has to be for the primary disorder. Then cardiac pathologies which can produce the arrhythmia, again, when I say where there is involvement of the heart as such, coronary diseases can present with arrhythmia, high blood pressure, cardiomyopathy, valve disorders. Now, in these conditions, a thorough evaluation is necessary. So, I don't say that every patient of arrhythmia has a risk factor, but every patient of arrhythmia has to be evaluated for the cause as such. And if there is some critical cause, like an injury from a heart attack, it's a very critical condition, and in that condition we need to have other effective management. So, I don't suggest I don't have any specific plan of treatment for the arrhythmias, but I would focus on the reason for the arrhythmia, and whenever there is such reasons which are beyond our scope, I would not have a hesitation to refer the patient to a facility where a cardiac monitoring or even a pacemaker. At times, some of these conditions may require pacemakers as such. So, I will not go into the detail of like when the pacemaker is required and so on. But the basic issue is filtering that patients, identifying that patient where the risk is more or not. So, every patient of arrhythmia need to be evaluated. And a good number of patients, virtually they can be neglected. In a good number of patients, they need to be evaluated, and that part is a very sensitive part, and it needs all that elaborate workout as such. With this, I think, I don't suggest any specific treatment for the arrhythmia as such. With this, we come to the end of it. Summary is the same, like if we are careful, if we are having a very selectivity, definitely there is a significant area where we can contribute with the Ayurvedic treatment. So proper discretion of morbidity and mortality is necessary for Ayurvedic management. That's all what I would like to convey. With this, thank you. Thank you, Asif. Right.
Some patients, they complain of palpitation, frequent palpitations.
Yeah.
Sometimes some people, I've seen one patient having palpitation, continuous palpitation since last 6 months. Actually, she was evaluated with all cardiac investigations and all. Nothing was there, no abnormality was detected. But still, she used to continue to have that palpitation, continuous, non-stop palpitation.
Okay,
but the patient improved, definitely.
I agree with that.
Yes.
Patient presenting with the palpitation, one of the very common condition is supraventricular tachycardia. That supraventricular tachycardia needs to be identified with either a simple ECG or maybe a continuous monitoring of the ECG. Hortons now, 24 hours ECG recording is necessary. So arrhythmias, the standard now, benchmark is that Hortons instrument. 24 hours continuous ECG monitoring is the standard benchmark where you can identify any potential arrhythmias. Now, the point is, as I told you, you have a good number of patients with these abnormalities where no identifiable pathologies are seen. Among those causes where no identifiable pathologies are seen, the commonest cause is stress, obesity. Patients who have obesity, they tend to develop this palpitation as a symptom. And the stress, as simple stress, psychological stress, as one of the common causes of the palpitation as a symptom. And anemia. Many times unidentified anemia patients, they present with the palpitation as a symptom. They may not have a cardiac pathology. These are the commonest. Hyperthyroidism is another of the condition where palpitation is known. So when there is no cardiac pathology, we need to rule out that. When you have ruled out all that, then it becomes only a stress condition. In that condition, I would safely prescribe Saraswatarishta. That's the point. But when there is a supraventricular tachycardia, now another of the areas, supraventricular tachycardia, it's resistant to the contemporary modern treatment. Modern medicines often, these drugs often may not produce the satisfactory results, or many times the adverse effects are more than the real trouble as such. In that condition, Prabhakara Vati and Arjuna-Arishta helps a lot. So I have a good number of patients with the supraventricular tachycardia without any ischemic pathology. Again, if there is a ischemia, of course, there is a limitation. Non-ischemic supraventricular tachycardia pathologies, there is a scope for the treatment. But other conditions, atrial fibrillation and so on, there is a need to have a specific protocol. You may require more effective treatment than simply with our medicines. I think that's the point. And obesity patients, reduction of the weight, if possible by any means, would help. And again, the yoga pranayama is another area. When there are only the palpitation as a symptom, no other signs, I would recommend the patient to have pranayama. Maybe I may give any other medicines. No, I don't say that I won't give the medicines. I may give any other medicine depending upon that. And pranayama is something which produces a very huge, significant change, as I have observed. Right.
Maybe anything in case of LVF,
LVF, I think I have referred to that issue. Hypertrophy, when there is a acute left ventricular failure, of course, we have a very limitation. I don't have an effective Ayurvedic management. I don't say I don't treat the patient. I treat the patient with digoxin and so on. That's the other part, if necessary. I do treat such patients in our hospital. But my clinical practice, OPD practice, I don't use that. That's a case where we have a limitation from Ayurvedic point, acute left ventricular failure. But chronic, I think the point which I have referred to, like Punarnamandura, even in a carpulmonal condition, it could be Shwasakutara Punarnamandura. I think that point I didn't refer to in this part. Earlier part I said, like, if the patient has a carpulmonal, Shwasakutara Punarnamandura is prescribed, and that produces satisfactory results. It could be often a co-prescription, like a patient with acute left ventricular failure, if I have to manage in my ward, I would be prescribing digoxin, maybe the other diuretics as per the necessity. Along with that, I may give I usually prescribe Shwasakutara Punarnamandura, and that produces the results. But these are some areas which are beyond the routine OPD level practice. You need to admit the patient, observe the patient, and many times that co-prescription issue. I think we are limiting ourselves to Ayurvedic prescriptions alone, so that part I have not referred to. Sir, please, sir.
A healthy person, how can we prevent a cardiac problem?
How to?
For a healthy person, what can be taken to prevent the heart cardiac problems?
I think I have already referred to that issue. One is diet.
Any medicine, drugs,
I don't suggest
some
any-
rasayanas.
a non-medical intervention than the medicines. Among the diet, of course, now these days it has become a very fashion like, Ashwagandha, okay, fine, Rasayana, fine, it can be. So that's another issue. But my preference is it can be managed with the diet, and there again it's the Nitya Rasayana. In the Nitya Rasayana, it's about Ahara, Vichara, Vihara and so on. Two important issues about the diet and this stress. These are the two important causes. Stress has to be reduced and the food intake has to be reduced. That's one. And then body weight. So if these three are handled, you can reduce the risk to a great extent, but there is no question of 100% risk prevention. There is always, once you have a heart, there is a risk of heart attack also. That's the other part. But that can be reduced effectively. That's the point.
Yes.
I don't recommend any drugs. Now, for my patients, I say no drugs as such, very clearly. Because the issue is, it's not about the cardiac issues, but in any condition, once you administer the drugs, the patients would have some confidence about the drugs and they would not follow the protocol. This kind of an experience I have seen in obesity. Now, if a patient comes to me for the treatment of reduction of weight, now I say no entry. I will say no medicines to the patients. Earlier I used to have that. Very interesting issue. I remember about a patient whom I have treated in 1989. 120 kgs weight, and at that time the patient's husband had a premier car, and his back seat, he would sit in between the two lanes so that there will be no stress on one tire. And this patient came to me with an idea like there could be a specific treatment for obesity. And at that time I remember Dr. U.K. Krishna and myself were together at that time, and we made this yoga of this Shilajitu Loha, which is mentioned in Charaka, that Medogna Dravya, 6 drugs, Shilajitu, this Loha Vasma, and then Trikatu, Triphala, these drugs are, and then prepared yoga and started giving to that patient. After I started that specific treatment, now very specific treatment for the obesity, after 1 month's treatment, weight increased to 122 kgs, and patient used to come to my clinic, and every time the patient recorded the weight, my weighing machine had to be again served because it would get jammed. After 3 months of treatment, patient gained 8 kgs of weight. Then the patient's husband told the secret. The secret is, because the patient is taking the medicines, she would say like, now why should I take care of the food? I will eat everything. If there would be no medicines, patient would be bothered about the weight and she would not take the medicines. I couldn't record her blood pressure. I still remember, I couldn't record her blood pressure because my blood pressure cuff would not be possible to put around the arm. So it's only the guess like blood pressure. This is the situation, and it's to a great extent it is true. Particularly patients who have gone for physiotherapy college, hospitals, and then weight reduction. Same issues. As long as they are there in the treatment, the weight reduces. The moment they go home, there is a very significant rebound weight gain. So all that issue is, it's about the caution which has to be inculcated in the lifestyle. So now last 15 or 20 years maybe, I have not prescribed any medicine for any patient with obesity. Every obesity patient, I would say, unless there is a hormonal pathology. Patients with a hormonal pathology and disease condition, that's another issue. But otherwise, I have not suggested any treatment for obesity. Patients coming to me for obesity, I would say, I don't treat that. You may go to anywhere. And there are easy ways of making money if you have some method of reduction of the weight. And what I feel is, you can reduce the weight temporarily, but in the long run, it has to be a habit which has to be inculcated by the patient. That's my version. Of course, it's open for all debate, like there is a possibility of disagreement, fine, but this is what I have understood, right? So, this is again issue. The congenital heart disease is a mechanical pathology, and I generally I generally don't treat that. I generally don't use that in any treatment. As I have told you, congenital heart disease is only about the prophylaxis, and my preference is in the children and congenital heart disease because they have a long life. I would not take the risk. I would always suggest wherever there is a possibility of, or where there is a need for surgical treatment, I recommend the person to undergo surgical treatment. But there are certain conditions where the surgery is not necessary. That's the point. But adult, that I think I have clearly mentioned that congenital heart disease seen in the adulthood is a totally different issue. So this kind of bifurcation, congenital heart disease in adulthood and children, you may not see in the cardiology textbooks. It's my assessment. Wrong or right is the other way, but that's how I assess the issue. There definitely yes, Prabhakar Vati has a scope to manage if the patient has a tendency for the cardiac failure. Okay, I do use only those Kumari Asava which do not have the bhasmas. That number 2, number 3 is about having that Loha Bhasma and the Tamra Bhasma, and I don't use those Kumari Asavas which have the bhasma inside, because that's not the original textual description. And from my point of view, there is no fun in adding the bhasma to the asava, which doesn't get dissolved. It will be only in the base of the bottle. So most of the times that bhasma is wasted. So if there is a need for administering tamra bhasma or loha bhasma, you administer separately. So I don't prescribe that. So I don't use those numbers of Kumari Asava. It's only Kumari Asava number 3, which doesn't have these bhasmas, or plain Kumari Asava. Which one? Ushirasa. Mrutyunjaya Rasa. This Rasaratna Samchaya. Of course, that point, you have plenty of that. Mrutyunjaya Rasa with Kajjali, Mrutyunjaya Rasa with this Hingula. And there are many. Yes, but that Rasaratna Samchaya, Mrutyunjaya Rasa. Jandu. No, same. The Jambiran Sama. No. It's the same. Of course, that part is true. Yeah, that's true. That part is true. And there is a Mahamrutyunjaya Rasa, another one. Many of the, I don't use that Mahamrutyunjaya Rasa, but majority of the Mrutyunjaya Rasa which I use is from either, again, Zandu or Unja, of course, those are the company name. And these companies use that Rasaratna Samchaya references. And that's what I have suggested. That part, of course, with the name of Mrutyunjaya Rasa, about 6 different combinations are in the text. Yeah, and also there are different combinations. And what I have collected is from the Ayurvedic formulary, API has collected same now. And for pharmacies, I think pharmacies, the guideline is API. Guideline is API, that's the guideline. And if you have a combination other than that API, there is a need for a separate license. I think, isn't it? Haudala? API allada bere bekidre bere license bekalla. So that's it. So API, of course, API plus Brithra and Lagutra is added now. In the good manufacturing practice, they have that guideline. But API is a final. In the API, what I have collected is from the API, and majority of the established pharmacies follow the same API suggestions. So that kind of a controversy, confusions, with the Kumari Asava also you have around 6 combinations mentioned in the text. Majority, a good number of drugs, medicines, you will have that kind of issue. So there, we have to select one and then follow that. That's it.